the percentage of women that are conceiving unprepared is too large, and that needs to change.
The incidence rates tend to be higher both in North Africa and in Sub-Saharan Africa, and we've got to bear that in mind, I think, when treating populations also in the UK.
So far, we know that having type 1, pre-existing type 1 or type 2 diabetes is a risky pregnancy.
Looking at it from a cultural perspective, that's what's important here. Hello? Hello? I've got no breath left, so I can't shout. I just came up the stairs as opposed to using the lift. Hi. So, welcome back, everybody. Excuse my panting. Anyway, listen, to important stuff. As I said to you, this conference is going to change you. Are you ready to be changed? Okay, are you ready to do some changes as well? Okay, so we have two fantastic speakers, absolute experts in the field of diabetes in pregnancy, and looking at it from a cultural perspective. That's what's important here. That's what we need to learn about. That's what we need to do something about. So I'm going to, first of all, introduce Dr Tolu Shonibare, who is a consultant diabetologist who works, now some of you who live down here may not know the North, but there is a place called the North. Leeds, is it? Leeds and Wakefield, okay. So Dr Tolu Shonibare is going to kick us off and looking at pregnancy and diabetes and the cultural considerations thereof. So I'd like to welcome you to the stage.
Hi, my name is Tolu. I'm one of the consultants. I work in Yorkshire, West Yorkshire, so that's Wakefield, Leeds. For those of you who would like to visit, Yorkshire is a very beautiful place. So before I get started, I just wanted to thank the Diabetes in Africa team and the admin team for inviting me to speak. I came for the very first time last year. I was so impressed, and I thought I've got to come back again. So I'm glad to be someone who's contributing. So thanks to Joan and the whole team. So I'm going to be talking about diabetes in pregnancy, the cultural considerations. My specialty interest is in maternal diabetes and endocrinology. And essentially, this is going to be a build-up to the fantastic Professor Meek's talk, which will come after mine. And essentially, I'm just going to be discussing what we already know about diabetes in pregnancy, what information do we need, and what are we going to do about it. So that's where we're going to focus on. So when we talk about diabetes in pregnancy, so this is talking generally now, by and large, most of the people who have diabetes in pregnancy will have gestational diabetes, which I'm sure you've all heard of. So gestational diabetes is a temporary form of diabetes which women have when they're pregnant. After they've had their baby, the diabetes disappears, but there's a reason why I'm doing that. And then the other women you might encounter in clinical practice are women who have pre-existing type 1 or type 2 diabetes. So about 87.5% of women with diabetes in pregnancy will have gestational diabetes, and about 7.5% of these ladies will have type 1 diabetes. 6.5% in type 2, although the number is increasing very, very quickly, and I'm sure Prof. Meek will talk about that. In the UK, 5% of all pregnancies in the UK will have some diabetes-related complication. So when we talk about diabetes and gestational diabetes, the question we need to ask is, what do we already know? And there is a national audit called the NPID audit. There are also lots of clinical trials, the concept trial, which is concluded, and there's another trial called the PROTECT trial. And this is where we're getting all the information about what we know about diabetes in pregnancy. And currently in the UK, so this is from a general perspective, I will bring it I will narrow things down as we go along. But from a general perspective, about 50% of women will have type 1 diabetes, and then 50% of women will have type 2 diabetes. And I think the most recent NPID audit showed that 44% of these ladies had type 1. So the numbers change, but it's roughly a 50-50 split. And a woman who presents with type 1 diabetes in pregnancy, on average, would have had diabetes for about 13 years. So she will have established complications by the time she gets pregnant. A woman who has type 2 diabetes probably would have had diabetes for, let's say, about 3 years before. She might not necessarily have as many complications, but actually what's interesting is that the outcome is actually worse. So that's very, very interesting. So what do we know about maternal diabetes? So I'm going to focus on just pre-existing diabetes. Professor Meek will talk about gestational diabetes. So what do we know about women with pre-existing diabetes? We know that most of the risks are associated with women who have either type 1 or type 2 diabetes, although there are also risks in gestational diabetes. There are increased risk of having miscarriage, preterm labor, hypertension, preeclampsia. They might even have worsening. So if they have already established complications, this might get worse in pregnancy. And also, there are also psychosocial and personal challenges you've got to think about. So these are the complications that can happen in the mother. And when we look at the complications in the baby, so a woman could have a very big baby, so we'll call it macrosomia. And the challenge of trying to deliver a big baby is that it's quite highly likely that the shoulder will get stuck when it's coming through the birth canal. Sometimes you can have women that a baby that can go the opposite way. So they might have intrauterine growth restriction where you have a smaller baby for the dates. Sometimes the baby could be born with a very low glucose, because if you imagine, if a mother has a very high glucose and the baby is attached to the placenta, when they deliver the baby and the placenta comes out, suddenly there's no glucose from the mum, so the baby's glucose can drop to very dangerous levels. So it's very important that, women who have diabetes in pregnancy have good control. The baby could be born with respiratory symptoms. Women who have pre-existing diabetes, their babies are likely to go to a neonatal unit after birth. And sometimes, unfortunately, there is a slightly increased risk of having stillbirth or sudden death in utero. And if a woman has type 1 diabetes and goes into diabetic ketoacidosis, there's a 50% risk of pregnancy loss. So far, we know that having pre-existing type 1 or type 2 diabetes is a risky pregnancy. So I'm talking from a global perspective. So I'm going to narrow things down now. So when we talk about women with pre-existing diabetes, specifically Black women, the information that we get is from the EMBRACE report. So the EMBRACE report is an annual report that comes from the obstetric side of things, where they look into the outcomes for women who've had either some form of mortality or morbidity. They look into things in quite detail to find out why the pregnancy outcome was poor and what they can do about it. And also, there are also parliamentary publications as well that look into why Black women, the outcomes are poorer. And also, from what we've observed in clinics, so Black women who have problems in pregnancy, there's certain things that clinicians have observed. So things to know, the cultural considerations for women who have pre-existing diabetes. The first thing to remember is that a Black woman or a woman from an ethnic background is 3 to 4 times more likely to have pre-existing diabetes or type 2 diabetes compared to her white counterpart. And also, what's interesting about the Black population and by and large the ethnic minority population is that they have a higher risk of developing diabetes, but also they have a higher risk of developing diabetes quite early. So, the average age of onset is about 40 years, but in the Black populations and sometimes the Asian population, that happens almost a decade earlier. So these are things to remember when women who are, Black women, when they get pregnant, these are things to remember, that by the time they come to see you in the clinic, they might already have established complications. Type 1 diabetes is a lot less, but the numbers are increasing. So we're seeing more and more people because if you look at sub-Saharan Africa, or if you look at things globally, type 1 diabetes in Black populations is a lot less. But because people are migrating around the world, the number of type 1 diabetes is definitely increasing as you go. And I think there's the same data in America. And sometimes when these ladies, when they get pregnant, before they get pregnant, they already have, for instance, very uncontrolled blood pressure. They might already have established disease, kidney disease. So they might be obese. So they have established metabolic complications even before pregnancy. So we know that having diabetes, for anyone who has pre-existing diabetes in pregnancy, it's a high risk. But women who are from a black or ethnic background, they're even a higher risk because they have established metabolic complications beforehand. And also, when these ladies get pregnant, that if they have diabetes, it's highly likely that their diabetes is not controlled. So they go into the pregnancy as a high risk to start off with anyway. And what we find, and there's a slide to show this, we're finding that a significant amount of mothers aren't prepared for their pregnancy. So this is the National Pregnancy and Diabetes Audit, which happens on an annual basis. So this is the last publication so far. And what we know is that pregnant women with type 2 diabetes are more, pregnant women with type 2 diabetes are more likely to come from an ethnic minority background. And also there's this thing about social deprivation as well. So they're more likely to come from deprived areas. And these are the things that lead to health inequality. And also, when you look at women who have type 2 diabetes, the outcomes are worse, compared to any form of other pregnancy. The outcomes are a lot worse, both for the mum and for the baby. So this is a slide from the Embrace report. I won't go into too much detail because this is going to be addressed in the next talk. But if you look at a woman who, when you look at the stillbirth rates, for women who have pre-existing diabetes. If you have a white woman, the white woman is, I think the rate is 2.78, so at the top, so your top left-hand corner, but on your bottom right corner, you can see compared to 2.78, for a black woman, her risk, for her stillbirth rate is 8.10, so it's almost 4 times more. And that's a combination of ethnicity as well as deprivation, which contributes to having poorer outcomes from the pregnancy. So the next question we know, so the first thing we know is that women who have pre-existing diabetes in pregnancy, they're higher risk. If you're black, your risk is even higher. The next question is, are they well prepared for pregnancy? So now that we know that they have a pre-existing higher risk, are they well prepared for pregnancy? Again, this slide is from the National Pregnancy and Diabetes Audit. When you compare all the races, so this is the top graph, when you compare all the races, type 1 is the darker blue, so type 1 is the darker blue shade, and then type 2 is the grey shade. So you can see that the amount of women that are prepared for the pregnancy is actually a lot less. So again, this is where we need to do some work. So when we talk about lady being prepared for pregnancy, what do we mean? So I suppose the first thing is when a woman who has pre-existing diabetes, if she's of childbearing age, we need to have conversations with these ladies to say, are you thinking about pregnancy? Are you thinking about starting a family? And these conversations need to happen not just when they're ready. It needs to start from when they're about 16 years old, from the transition, or what we call the transitional age, when they're young adults, if they were diagnosed with diabetes early. The reason why is that they can start planning ahead, so they know that in the future, if they do decide to have a baby, then there has been some thought that has gone into it. And also, you need to think about the HbA1c. So the previous slides show that, if your HbA1c is higher, then you're more likely to have poor outcomes, both the mother and the baby. So a HbA1c of less than 48 is when we would advise a lady to she's safe to get pregnant. Anything higher, we would ask them to wait, get the diabetes control better, and then consider starting for a baby. But if a HbA1c is as high as 83, we would advise them not to get pregnant. So these are the things that you need to consider in a woman of childbearing age. But the question is, are we addressing this when they come to see us in clinics? The next thing is folic acid. So folic acid, there's a lot of debate about folic acid, but any woman who's trying to get pregnant, sometimes they go on multivitamins, and it wouldn't normally have folic acid in there. But for women who have pre-existing diabetes, so this is not gestational, but pre-existing diabetes, they should be on a higher dose of folic acid, which is 5 milligrams. And from the point where they think they want to start having a pregnancy, this needs to be started. So not just when they get pregnant, actually, it needs to be before. And this is coming from evidence that women who are on high-dose folic acid, there's decreased risk of things like neural tube defects and neurological complications. And also, having pre-existing diabetes in pregnancy can be quite stressful because you have to visit the clinics quite often, you have to see a dietitian, you have to see a diabetes specialist nurse, and it can be quite stressful. And our role is to support women, to let them know that they're not there on their own, because there's lots of things to consider. There's lots of cultural factors to consider when women have, pre-existing diabetes. And our role is to try and support them as much as possible, and also try and make sure that they enjoy the pregnancy. If you have a lady who has pre-existing diabetes, who has very high risk complications or metabolic factors, then you need to be referring them to a specialist preconception clinic. So the answer to preparing a lady for pregnancy is to make sure that they are referred to a preconception clinic. And this could either be in the community, or this could either be, in a specialist clinic. So it's very important that these ladies are highlighted and referred early to a preconception clinic. So in a preconception clinic, we would look at the diabetes control, we would address folic acid. Quite often, these women will also have things like high blood pressure, they'll have complications like high blood pressure or kidney disease, and sometimes they might be on medication that are teratogenic or not good for the pregnancy, and this will need to be reviewed, so that by the time she gets pregnant, she's not on any dangerous medication that could affect the pregnancy. You also need to look at weight management. If they are smokers, you need to look to try and stop them from smoking. So just to summarize, women who, and this is from a global perspective, the factors that affect a mum's outcome when if she has pre-existing diabetes, the factors that affect their outcome, the first is that they're not planned, they're not well prepared for pregnancy. And this is a major problem. You need to think about your patients who are high risk, and specifically your patients from certain ethnic backgrounds who are even higher risk. So we need to make sure that these ladies are well prepared for pregnancy. And if they have associated metabolic risk factors, for instance, obesity, overweight, that needs to be addressed as well, and it needs to be addressed on time. It needs to be addressed early. You also need to think about social deprivation as well. What are the cultural factors that might make her not be able to look after her health? Does she have enough money to buy healthier foods? Does she have enough time to be able to exercise, etc.? And also, and we know that deprivation and race are interlinked as well. And then you also have to look at psychosocial factors. So I'm not going to talk about gestational diabetes because that will be addressed in the next talk. But what we need to do is identify these, certain, women who are black. We need to identify them as high risk. We also need specific data to look into, and this is the honest fact. I know things are changing now, so we're looking into mums from certain ethnic backgrounds. We're looking to see how well they do. From the parliamentary reports, we know that they don't do well, but we need more data. We need to find out what is it about these mums that makes them at higher risk. We also need to publish the data, look at everything, dissect the data. So we definitely need more research into this area. We need to increase health awareness. Okay, so and this is quite a good talk. This is quite a good forum for this, increasing health awareness among clinicians and also the patients as well. I think in the previous talk with the foot, they talked about people's culture. So what you don't want is to be clashing with people's culture when you're trying to manage their health. So you need to be giving them tailored, culturally tailored advice to help them to manage their pregnancies better. So what is needed? We need patient empowerment, and forums like Diabetes Africa is very good for being able to identify specific populations so that we can give them empowerment to talk and tell us what it is that we can do to make things better. Like I mentioned before, we need more ethnic-specific data. We need to raise more awareness about being prepared for pregnancy, and I think that's where it starts. If the women are well prepared, then it's highly likely that the outcomes will improve. We need to make sure that we adequately manage their comorbidities as well as their longer-term risks and the metabolic factors. And we also need to have cultural humility and also offer culturally tailored advice. So I think that's the end of my talk. Okay.
Dr. Shonibare, thank you very much for taking us through a whistle-stop tour of diabetes in pregnancy. So I'd like to welcome to the stage Professor Claire Meek. And Claire is a professor of Chemical Pathology and Diabetes in Pregnancy at Leicester Diabetes Centre. She runs the Diabetes in Pregnancy service at the University Hospitals Leicester. And for those of you who don't know Leicester, it's a large ethnically and socio-economically diverse place. So as you can imagine, there's quite a cohort of people with early onset type 2 diabetes from the Leicester area. Professor Meek started her research career at the University of Cambridge and was studying nutritional interventions to improve glycemia and weight loss in people with type 2 diabetes. She's received lots of awards nationally and internationally, and we're going to welcome Professor Meek to the stage. Thank you. Just to let you know, as I said to you, expect to be changed by what you encounter today, and also get ready to participate, because this conference is for you, but about you and including you. As I said at the beginning, you're all very welcome. You have something to contribute. After Professor Meek's talk, we'll have a brief video, if we've got time, because actually what I'd like to do is to get input from people here.
Thank you very much. Let me just get started. So thank you very much again for the invitation to speak. It's a real pleasure to be here, and lovely also to have the chance to present with my two esteemed colleagues. So I thought I would take a slightly different approach, actually, in that we have 10 minutes, and what are the 4 areas, I suppose, that I think we need to highlight today in order to make changes, in order to improve things for women with diabetes and pregnancy who come from Black backgrounds. So I'm going to talk through 4 particular things. Now, we've heard a lot about feet today, and we've seen lots of gruesome pictures, and actually pregnancy in a sense is a little bit more fluffy than that, isn't it? You get cute babies and things, but of course actually what we're really talking about is really about preventing maternal and baby deaths. That really is our aim fundamentally in the pregnancy clinic, to help get good outcomes for mothers and babies from all backgrounds. So I want to have that really as absolute forefront of our minds. But there's another few areas I think also need attention if we're looking to improve outcomes for Black women. One is about screening in gestational diabetes. Another is about screening for type 2 diabetes and ideally preventing early onset type 2 diabetes after gestational diabetes. And also, which I'm not going to talk a huge amount about, but the equity around technology use in type 1 diabetes. So first of all, although we feel within the UK that we have major issues in terms of diabetes and pregnancy, I think it's really just worth putting this in an international context, that actually compared to many other areas, we actually have among the better levels, among the lower levels of diabetes and pregnancy, of gestational diabetes. But actually internationally, this affects around 20 million women worldwide. So it's a huge international burden of disease. And within the UK, we've really seen incidence rates increasing year on year, and that causes real challenges for clinical services in terms of management. But it's also just worth highlighting that actually, naturally, the incidence rates tend to be higher, both in North Africa and in sub-Saharan Africa, and we've got to bear that in mind, I think, when treating populations also in the UK. So just to reiterate my first point, really, that actually really what we're about is about trying to prevent serious adverse outcomes both in mothers and babies. And we know that pregnant women with diabetes of any ethnicity are around 3 times more likely to experience cardiac arrest or in-hospital maternal death compared to those without diabetes. This is just devastating. And of course, sadly, those rates are even higher in Black women. So you can see here maternal mortality rates in England in 2009 to 2022. And you can see that Black women on the left there are vastly above all other ethnic groups. And you can also see that actually, according to deprivation, there's a huge impact of deprivation on maternal mortality here in England. So these figures are one of those things, as Joan said to us earlier, that we shouldn't be accepting. This is something that we need to do something about. It's also fair to say, of course, and you've already seen this slide, but actually we care about baby deaths as well. And baby deaths are also much more likely to happen in deprived communities and much more likely to happen in Black African people. So there's a lot of work really to be done there. We need to increase awareness, but also that intersectionality between deprivation, ethnicity, and sometimes education is also something that we need to target and think through. So moving on then to screening for gestational diabetes. Well, what actually is gestational diabetes? Well, it's really hyperglycemia with first onset or recognition in pregnancy. But of course, this sort of obscures the fact that actually it's a huge spectrum really of disease here. So you've got on the left an isolated pregnancy phenomenon that resolves postpartum, but actually there's a lot of other people who are diagnosed as having gestational diabetes who actually might have pre-gestational pre-diabetes, undiagnosed type 2 diabetes. They might even be developing early type 1 diabetes. And actually it's a real challenge for us trying to work all of that out in terms of in pregnancy clinic. Now, we did a study a few years ago in Cambridge looking at oral glucose tolerance test completion. So the OGTT is the diagnostic test for gestational diabetes, and if you don't attend and don't have it, then you can't be diagnosed and we can help manage the risks. So actually this is a really important aspect to this. Now, in our study, Black women were 2.7 times higher in terms of the risk, if you like, of non-completion of the OGTT. And there were a number of different reasons for overall for non-completion in the study, such as glucose not tolerated, unable to get convenient appointments, social and mental health issues. So there's a range of issues, I think, that need to be tackled or thought through when we think about making the testing process more accessible and more equitable. Moving on then to screening for type 2 diabetes. So type 2 is a huge issue, as we know. We know that women who have gestational diabetes are at high risk of early onset type 2 diabetes. We know that that results in an average of 10 years of life lost in women. So that's 10 years of looking after those children, 10 years of keeping families together. We also know that actually early onset type 2 diabetes carries very high risks of complications such as kidney disease, hypertension, dyslipidemia, cardiovascular disease. So we need to do more to prevent early onset type 2 diabetes in this population. So what actually happens after GDM? Well, data from the States suggests that Black women are more likely to develop type 2. Some work done within the UK, within the CPRD General Practice database, also suggests Black women are more likely to develop hypertension, which is very much consistent with what we know. And also, there's been some evidence that actually screening rates through testing annually for type 2 diabetes after gestational diabetes is less likely to occur in Black women. And we don't really know why that is, whether that's a case of poor accessibility of services or awareness of it as an issue. Still a lot of work really to be done there. So thinking through then how we also then look after our mothers with type 1 diabetes. Well, we know that actually there's been a lot of work done, particularly through NHS England, really related to the roll out of a new technology called hybrid closed loops. And hybrid closed loops are essentially a glucose sensor, an insulin pump connected with a sort of fancy bit called an algorithm that tells the insulin pump how much insulin to give based on the glucose levels. And these are really known to improve outcomes, well, improve glycemia really within the context of women with type 1 diabetes in pregnancy. They've also been tested, there's a number of different ones, but really the one registered, approved for pregnancy use in the UK is the CAM-APS algorithm. It's just important to mention that actually there is a bit of a sort of process to this really in terms of getting hybrid closed loop rollout. So thinking through the setup, often that would be preconception in Leicester, if we can do that, preconception care for type 1 diabetes. We then have to think through the practicalities of how we actually implement hybrid closed loops during pregnancy, particularly in the delivery period. There's a period of optimisation when people start. Through the pregnancy, the care might look a little bit different, and clinicians might need a bit more training to be able to offer that. And then, of course, labour, delivery and postnatal care also change a little bit through the hybrid closed loop process. It's important, though, to say that really all of our data about hybrid closed-loop use in pregnancy is vastly more representative, really, of white populations and not of black populations. And there may be a range of different reasons for this in terms of the location of where the studies were run and so forth. But I think another issue that we have is concern, perhaps, that actually the technology isn't being offered as readily to women from black backgrounds. Now, we actually in Leicester have been doing this quite a bit. We've had a lot of HCL rollout over the last year or so, and we've had great experiences actually with women from all backgrounds, which is encouraging. So I'm not going to talk more about that because I know Mira is going to speak a bit more about technology and equity later on today. So just then really to leave with a sort of summary. So the key areas of unmet need that I think we can do something about and should be seeking to change would be firstly preventing maternal and baby deaths. How can we reduce deaths in the context of diabetes and pregnancy? But also actually how can we improve women's experiences? How can we listen better as healthcare professionals? How can we be more approachable for people who have concerns? Secondly, I think there's an issue regarding the screening for gestational diabetes and how can we design testing strategies that are accessible and appealing to women. Thirdly then, how can we raise awareness about early onset type 2 diabetes? How can we improve the pickup of type 2 diabetes after gestational diabetes? And more generally, how can we actually prevent the burden of early onset type 2 diabetes within our communities? And then fourthly, looking at technology use in type 1 diabetes, how can we ensure that black people are benefiting from the new technologies on offer? Are there additional ways we need to think through support in order to make sure that people get the benefits from those? So thank you very much. I just wanted to leave by highlighting two other things, if you don't mind. First of all, within Leicester, we are absolutely dedicated to improving outcomes for women with type 1 and type 2 diabetes. And with this in mind, we are just about to launch our new DOMINO study, funded by Diabetes UK, which will be seeking to recruit 400 women with type 1 diabetes and 400 women with type 2 diabetes in pregnancy. If you are interested in joining us as a site for that, please do let us know. We would be delighted, and this provides a great opportunity to look more in depth actually at inequalities within our pregnancy care. And then the second thing really to leave you with is that Diabetes UK have just launched this excellent scheme to promote black leaders in diabetes through an internship and PhD studentship. And this is really to tackle the underrepresentation of black people in academia and clinical care nationally. So I would just like to highlight that to you. They are currently looking for applications from aspiring leaders to the PhD scheme, so something for you also to have a look at. So thank you very much.
Can you hear me okay? Yes. Yeah. Okay, so as I said, this is going to be very interactive. We do have a video that we'd like to show, but what I think I'd like to do, because I want to get people's participation in the room. So what I'd like to do is to have our panel up here. I want to hear your experiences, your questions, and then at 12:30, I'll show the video. Those of you who want to have 50 minutes for lunch can watch the video. Those of you who feel that you need to go and eat can go downstairs. But what I'd like to do is to have the panel, and I want to welcome to the stage Nuru Clark, who's an antenatal senior diabetes specialist nurse at Barts Health NHS Trust. And she provides support for pregnant women right from preconception through pregnancy, delivery and beyond, yes? And also does the submissions for the National Pregnancy and Diabetes Audit. So welcome, Nuru. Claire, Tolu, would you like to come up to the stage? We're going to stand, because actually I'm standing because I use up more calories that way. So we're going to stand. If you want to stand, if you want to ask a question, if you want to share your experience, just say who you are, which area you're from, what your speciality is, what your question is. Because remember, we said this conference is about change. Don't accept any longer the change that we can do something about, okay? So, anybody got a question? Because if you haven't, I've got one. And don't be frightened. Okay.
Thank you. Brilliant sessions today, without a doubt. My name is Bisola Shonibare. I'm a pharmacist, and I work down south in Swindon. And my specialty area is actually CVRM, so this is cardiovascular, renal, covering the whole lot, or trying to anyway. My question is around, or maybe it's an observation more than anything else. Having recently had some diagnoses in ladies that are in the preconception stage and referring them on to specialist intervention with some success stories. I guess my biggest concern is about, we know why. My concern is how, in terms of resources and funding. And while that should not be an obstacle in achieving or moving on, I'm recognizing the lack of standardization in care more than anything else. And also, and I guess that is about around education of professionals. Because I can't, at my stage of knowledge anyway, I cannot challenge. I'm sending people to specialists because they're specialists, but you do find there is variation and it's not standardized care. And I guess overall, in summary, is just to say, how do we bridge that? Not expecting that you would necessarily have an answer, but perhaps share opportunities that you've come across in terms of from primary care to secondary care interface. Thank you.
Thank you very much for that question. That's a very, very important question. And actually, before, when we were planning the meeting, this was one of the things, because a pregnancy toolkit is being in the process of being published. So I think when it comes to preparing a lady for pregnancy, a woman who has gestational diabetes, she doesn't know she's going to have gestational diabetes, so you can't really prepare for that. But a woman who has pre-existing diabetes, ideally, when they get diagnosed with diabetes, if they're of childbearing age, that everyone with diabetes who's diagnosed with diabetes will have their annual screen. I call it the annual MOT because a lot of my patients tend to relate with that. And if they're of childbearing age, so this is in primary care, that's an opportunistic time to have that conversation. Yes, it's an extra 5 minutes, but it's a very important 5 minutes, because you can speak to these ladies and say, well, if you're planning for a pregnancy, number one, your HbA1c needs to be under control to reduce your risks of having a poor outcome for both you and the baby. And then if you, for instance, you have a young girl who has diabetes and wants to get pregnant, but she's not very well controlled, ideally they should be referred to a preconception service. So in Yorkshire, we run, or mid Yorkshire, we have three preconceptions clinics per week, because we're spread across 3 different sites. And this is something that has been agreed, I think previously they used to call them CCGs, but this is something which we agreed across the board, that any woman who has very complex diabetes and wants to get pregnant, then they will get referred to our services so that we can prepare them for the pregnancy. And if they can't prepare for the too high risk, then we will tell them that. We will be honest with them and say that pregnancy is too high a risk. Yes, we have managed very complex pregnancies in the past successfully, but it's important to find out what's available in your area. I agree that across the board, then, because when you look at the National Pregnancy and Diabetes Audit, unfortunately, one of the places that we fail, and this is for all pregnancies in the UK, diabetic pregnancies in the UK, preconception is something that we don't do very well on. So ideally, in an ideal world, we would have, every time a GP meets in primary care, or it doesn't have to be a GP, it could be a specialist nursing community. Each time you meet a young girl who, even if she's not planning for pregnancy, that conversation should happen anyway and every year. And then if they're complex, then they should get referred to a specialist preconception clinic. Does that answer the question? Yeah.
Claire or Nuru, did you want to?
Thanks, Claire. Hi, thank you. Thank you, Diabetes UK, for inviting me. I think as a diabetes specialist nurse, what I see happening that really needs to change is the non-referrals to preconception clinic. And it's not necessarily a preconception clinic that's needed, but that talk with the women that are of childbearing age. Because a lot of these women are actually getting pregnant unprepared. I don't want to sound like a parrot repeating what's already been said, but the percentage of women that are conceiving unprepared is too large, and that needs to change. I think each of us who has the opportunity to speak to that lady about planning for pre-pregnancy should actually take that up. And I find an easier way of actually discussing and convincing a woman to prepare for pregnancy is by letting them know of the potential for the complications in pregnancy. And because I've actually got lived experience cases, I can speak about that as well. Yeah?
Thank you. I'll just speak briefly actually about the point that you raised about funding. So within Leicester, we were able to use some of our T2Day money to set up a new preconception clinic. And we also were able to spend a little bit of money on a member staff to go out. We started with the 4 general practices within the area that had the highest prevalence of people with early onset type 2 diabetes. But our aim is to start with those 4 and then spread out to the 20 practices within the LLR region where we stay. And we've been able to essentially then to sort of case find people. So actually a lot of the, one of the challenges with preconception care is that not everyone is planning a pregnancy. Sometimes they just get pregnant without planning really. But it allows us to look at those records, see people maybe who've had a few miscarriages in the past, and it allows us to send, if you like, a dedicated invitation to people for a service actually they may not have known very much about. I think also your point about cardiovascular and renal is really important, that we're still, I think, finding our way in terms of managing the people that we have with type 2 diabetes. There's very little research in that area to guide us, but certainly many of those women will have cardiovascular disease already. Many have certainly hypertension, very common. And I think we need research, but we also need to move forward in terms of how we're managing women.
Thank you very much. So, and also from a primary care perspective, I think that it is beholding on us to get it right first time. And I think, Tolu, you said about that conversation. When somebody comes for the annual review, sometimes you're a bit reluctant because you don't want to ask too many questions because you might get too many answers. But this is a vital question that you need to ask. And also a lot of people, a lot of women are under the impression they can have the folic acid that they can get from the pharmacy. If you're living with type 2 diabetes, type 1 diabetes, that is insufficient. So we here can spread that message. Yeah, there's a question.
Hello, my name is Neka. I'm a diabetes specialist nurse, lead and manager for a community diabetes service in North London. And my question is around younger people with type 2 diabetes that present in my clinic with very high HbA1cs from the Black community. And often when we do the assessments, we do find out that they're not on any contraceptives. And, you try to have that discussion around the importance of having that contraceptive in place to bring the HbA1c down before they can now think of planning a pregnancy, and they're not buying it. So I'm just wondering if there's any work out there or any kind of resources out there that could provide information to young girls from the Black community around, breaking the myths around contraceptives, because they do believe in conversations I have with them that it makes things worse. So it's just a question I'm putting out there. Thank you.
So that's a really complicated one, because it's not just not wanting to go on contraception, because I have a lot of people that say that it messes up their hormones, not looking too far. My own daughter doesn't want to use contraception, saying it messes up her hormones. And, and there's religious issues as well. A quick example, I've got a lady that hasn't even been a year yet after a cesarean section. She was actually booked for maternity care with an HbA1c of 98, not having known that she had pre-existing diabetes. So she's had a C-section, she's had a baby. Thankfully, the baby is fine. But because of religious considerations, she's not going to take contraception. And she's already had 2 miscarriages since that delivery, and that is less than a year ago. So it's a really difficult one. But for those that you can actually build a rapport with and educate, give them the TLC, if you like, and just explain that the complications are really not worth it, because if they do conceive with such HbA1cs, then your heart is in your mouth wondering when that phone call will come telling you, I'm bleeding. And then the miscarriage comes. Is it the diabetes? You know, questions that you can't really answer. So what can I say? I don't know if you guys have any, what's the word I'm looking for? Thoughts.
I suppose one point for me would be that actually this would be a great topic for another toolkit, actually, because we do recognise there's huge cultural barriers, both in terms of choice of contraceptive and the decision to actually take something. And that might actually be something within this forum that would be a very helpful way forward.
So, Prof, you know, the way Blue Peter used to do it. Here's one I made earlier. So we can't say here's one we made earlier, but I can say to you that certainly this panel is involved in preparing a toolkit to address these issues, because there's no point us talking about the issues, no point us talking about it and not doing anything, not being that change. So we are, at the moment, have a draft toolkit, which there is a QR code for, so hopefully we'll be able to share that with you. And we need your feedback, we need your input in order to make this as good as the tech toolkit, which you were given when you booked in today. One of the things that we thought in the toolkit, because we talked about being well prepared for pregnancy, is there culturally relevant information to let women know what well prepared for pregnancy means, what it looks like, that you have to have that 5 milligram folic acid prescribed. You can't go to the pharmacy and just buy it. That your HbA1c should be at a much more reasonable level than it usually is. And you need to come off some of the medication or substitute some of the medication that you might be taking for safer medication for you and your future baby. So, you know, culturally relevant things, whether it's videos that you can share. Remember I said my mum calls it WhatsApp, that you can share on WhatsApp. You know, things like that. We need to get your input for the toolkit.
Yeah, I just wanted to mention something that I think it's quite well known in the public realm that black mothers tend to do worse. And sometimes it's getting that detail across to them to say that actually women who have pre-existing complications or pre-existing risk factors, that could be one of the reasons. So it's trying to link the two together. I think there was a young girl, I think on Instagram, that died a few years ago, 2 years. I think her name was Nicole, and there was a big uproar about it. But it's coming back to the table to have those conversations to say that, yes, we can see that black mums are not necessarily doing well in pregnancy, but what are the root causes? As trying to link the two together to say that if you have type 2 diabetes, and chances are if you're black, you'll have it a bit earlier, and chances are by the time you're ready for pregnancy, you might already have complications or risk factors. So it's trying to marry those two outcomes together to say that actually you're actually a higher risk and something needs to be done about it. And as Dr. St John has said, is that having those conversations, preparing them properly for pregnancy.
And we're also going to make one comment, which is a bit controversial, in terms of the data and the way it's presented to us. We've had some fantastic slides here, which give specific information about African Caribbean populations. But try and find that information in the national audit, or try and find that information in the public domain. And we need that information presented that way in order to see what we can do, be part of the solution.
I was going to say, also healthcare professionals. I had a quick talk with Prof. Meek. Healthcare professionals, if you can get involved in any research, get involved. Even if it's just a little contribution, please speak to people who are already doing research and link up, because I think each person individually is doing their own little good in their own little corner. But if you link everyone together, it becomes a much more bigger force. So link up with people who are already doing the research, and also empower your patients. Tell them that, because I know you mentioned before that we need more women from Black and ethnic minorities represented. I think also you said that, represented in the research data, because you can't talk about outcomes when certain populations aren't represented. So we need that, we have that personal responsibility as healthcare professionals, and also for our patients, to get them involved.
Yeah, I was just going to say, we've had a set up a peer support group, and we're all talking about, obviously, what clinicians. We all also have to understand what their amongst their pregnancy needs other people that look like themselves and talk about those issues. So that I think that's another aspect that we need to.
Did everyone hear that? So Barbara's done some fantastic work setting up support groups for people who are living with diabetes. And she's saying that that's an arena for us to move this forward, more of the solutions.
Thank you. Just to ask, what is the relationship between overweight and outcome in patients with diabetes? And do you insist in your preconception that women lose weight as a way of protecting them from complications and hypertension and such?
Thank you very much. I will take that because we've done a few pieces of work actually related to this so far. So in fact, we just published a meta-analysis quite recently in Diabetes Care, looking at the effect of BMI and gestational weight gain on outcomes in type 1 diabetes in pregnancy. And essentially, I'm going to struggle to remember exactly here, but if you have excessive gestational weight gain, risk goes up very markedly, and it's something like 11% increase in risk of any adverse outcome for each 1 kilogram heavier you are entering pregnancy. So really important in type 1. In type 2, I've just been doing a meta-analysis with the lovely Sarah White here, and actually we've found that while there's lots of papers looking at BMI as a predictor of suboptimal outcomes, actually there wasn't even enough data in our meta-analysis, in our systematic review, to do a meta-analysis of that. So we actually need much better data for the type 2 population. We almost certainly think that BMI is going to be a really important risk factor, isn't it? But actually we lack that data at the moment to really show that, or to say, well, actually, what would our target be if we were, in preconception recommending that? I think that's why our study with Diabetes UK is going to be really important, because it'll be some of the first data we get about that collected really consistently across the UK. In gestational diabetes, we know that gestational weight gain is a major factor for development of GDM. We also know that maternal BMI is really important as well. We've just finished a study also funded by Diabetes UK, actually showing that actually a little bit of weight loss in late pregnancy improves outcomes for overweight and obese women with gestational diabetes. And we're talking really an average of 2 or 3 kilos. So for people who have GDM at 28 weeks, a little bit of cautious weight loss in that late period in pregnancy improves outcomes, but also reduces future risk of type 2 diabetes, as far as we can tell, lower postnatal HbA1c. So there's actually a lot of really good things we can do here. Preconception-wise, one of the things that we're using increasingly in preconception clinic are GLP-1 related medications with the aim to reduce weight. Those are generally really effective. The only issue is that you do tend to get quite a lot of weight regain. So I had one patient who lost 20 kilos only to put on 27 in the space of the next 6 months while trying for a baby. So I think we know that it works at a certain level, but I think we need to develop services that help prevent the weight regain afterwards, or give women a bit more dietary support and coaching. But certainly it's very widely used. Do you have anything you'd want to add?
I think this is because one of the slides I put up was that one of the ways we can get data is clinician observation. So women who are overweight, you also have to think about the anesthetic risk. as well. So because we run clinics with obstetricians every week, and quite often you'll hear them talk about a woman who's overweight. It was difficult to do the section. So that alone, and also the quality of the placenta as well. So women who are overweight will need to go either on aspirin in addition, as well as tinzaparin and blood thinner. So they tend to be higher risk. I just wanted to mention about, I think we haven't really touched on it, is that if a lady has gestational diabetes, it's important to tell them the after story. So we always say the diabetes disappears, but actually there's a big study that's ongoing, the HAPO study, where women who have gestational diabetes, although it disappears, if you follow them for 10 years, 60 to 70% of these ladies will go on to develop full-blown diabetes, as well as heart disease. So it's important that each time a woman who has gestational diabetes has been discharged, that's the point, that's where the hard work begins, that you have to tell them to remember that everything, in our trust, we do a fasting glucose after 6 weeks and then an annual HbA1c every year thereafter. Because if they're trending towards diabetes, that's where you can do the hard work to reduce the risk of developing full-blown diabetes. So I think that's another thing that I thought is worth mentioning. There's healthcare professionals, that for gestational diabetes, the hard work starts after they've had the baby. Managing the pregnancies are easy, is afterwards that, that's where the hard work comes.
And also they can refer themselves to the National Diabetes Prevention Programme if they've had gestational diabetes. So we've probably got time for one final question, Mira. Oh, was there some hands here? We can squeeze another one in. Okay. And then Mira.
Hi, my name is Yemisi, and I'm a pharmacist by background, but I work with Novo Nordisk as a medical advisor. And the question that I want to ask is about the clinical trials. So when I'm reviewing clinical trials, I'm always seeing a number of the patients that are enrolled are from a white background. And we know that diabetes predominantly affects those patients who are Asian, Black, etc. So I wanted to understand a bit more of what are the pain points that are why Black women specifically are not being included in clinical trials, and also with the DOMINO study, has there been any tools in place to help mitigate that?
So I think that's a great question. We understand and have understood for a long time that there are barriers to recruitment into clinical trials for many women. Education can be one barrier, having even just time and headspace, childcare, all of those things make it more difficult to have women from underrepresented groups as part of your study. Now, we have traditionally tried to tackle that in a number of ways. So the study I just mentioned, which is our clinical trial about weight gain and gestational diabetes, we actually gave free food, and we worked very closely with the first sort of 50 participants to make sure it was sort of tailored to various cultures, or at least to provide some input into that. And I think thinking a little more laterally can help you come up with clinical trial ideas, if you like, that should be actually, if anything, more appealing to people from underrepresented groups. That's not always possible, but I think making sure that you have, for example, honoraria, you've got your transport costs covered. You can offer a degree of flexibility in terms of where and when the visits take place. All of that's absolutely crucial. And of course, for a long time, we didn't allow anybody to bring a child into the maternity department. So actually, that's a major problem if you have no childcare. So I think, trying to make sure that the frontline staff on your clinical trial or observational study are aware of those barriers and seeking, where possible, to mitigate them at any opportunity is key. We have a number of things planned for DOMINO to help. Firstly, like translated materials would be one thing. We have been learning from the PROTECT study run by Helen Murphy and Eleanor Scott. They've been using kind of animations to help support recruitment and things. And we're also thinking quite a lot about health literacy. I think many of the ways that we do clinical trials, we have this enormous 9-page participant information sheet. It's really daunting. It's daunting for everyone, but it's actually especially daunting if English isn't your first language or you're a bit time poor, really. So there's a lot of things to think about in that. But also, I suppose that's maybe another good idea for a further Diabetes Africa session in terms of how we as researchers can make sure we're designing studies that are appropriately allowing for representation.
So Claire, we did that last year.
Oh, great. I'm sorry I missed it.
But maybe for next year. Mira?
Hi, yes, just going on from that, from what Professor Meek is saying, I myself have been involved in recruiting for Protect Our Site, and barriers to making a lot going on in their lives, other children to look after, work, the current pregnancy. What I wanted to ask about, and maybe Nuru will the most, is something that never really gets talked about. They are briefly about it at one point, right?
Sometimes.
But I think Nuru speak more about this better than I can, because she gets to know these women so well. But they don't just exist in isolation, do they? They're not in a bubble. They're there with their family, their partner, their mother-in-law, or whoever, their husband, their boyfriend. And actually, in order for them to be able to make these changes, that education not just for them, but for everyone around them as well.
Yeah.
Talking about raising that awareness. Yes, obviously we need to target that at the women, but actually everyone should be aware.
Yeah.
I don't know how we do that, because I do a lot of adolescent clinics, and I'm continuously banging the drum at all these 15, 16-year-olds about preconception. I see here what the person said about not buying it. They're just looking at me like, what is this woman talking about? This is not relevant to me. And TikTok said that the pill makes me fat, so I feel like the message does not land from me, but maybe the kind of advice on how we communicate that to the people.
Yeah, so we have a lot of that in the Diabetes and Endocrinology clinic and in pre-pregnancy as well. And going back to the point of contraception, especially, one lady said that her husband is not going to allow her to go on contraception. And so that's a problem. And if you remember, we also had a case whereby a woman was being forced to eat all those things that she was told to kind of limit during pregnancy. So we had to get the husband into the consultation and speak to her, but speak to the husband as well. And then you've also got a lady that was pressurized by family members to conceive. And because everyone around her had had a baby. And so she was told, you've got to try again, because she did. HbA1c is sky high, had a miscarriage, and was told, you've got to go again. And this is me trying to catch her to say, come to my pre-pregnancy clinic. You have to make sure you're on contraception. Don't go through this again, because it's such an ordeal when they do have that miscarriage after they've been trying. Maybe I should say they've been married and trying since then, and nothing's happened, and everybody's looking at her like, what's wrong with you? It's always a problem with the lady, not the man, yeah? This is what I find. So I think involving the partner, involving whoever it is that's in the support group in the consultations as well, that does help give a better outcome. That's what I find.
So we need your input. We need your advice. We need your experience. As I said, we're in the process of preparing a pregnancy toolkit. So if you'd like to participate in that, could you give me your email address at the end of this session? So if there aren't any other burning questions, one more question? Okay, as long as you guys don't mind not eating.
Thank you very much. I just want to touch back on the issue of recruitment of women from the Black community. I think one of the things we shouldn't forget is the issue of trust. So we know from our community there's a lot of mistrust. We don't need to look far back. During COVID, the uptake of the vaccine among the Black community was lower
than everybody else. And I think, how do we address this issue of trust, that, you know, we're not just making you guinea pigs for the sake of it. And I think that's one of the biggest problems we face with recruiting people from the Black community into clinical trials.
I agree. I think trust has always been an issue. I think this is where we all come in. So raising awareness with our patients, because we already have rapport with them, and is explaining to them why research is important. Because when policies are being issued concerning care of the population, it's based on research data. And if you're not included in that data, if you're not included in that research, how can that policy benefit you? So I think this is where we come into trying to gain their trust. So someone they've never met who's trying to recruit them might not necessarily get an uptake, except if that patient has understanding about research. But this is where you have to get them on your side to explain that, yes, we are giving you the best possible care, but the only way we've managed to get to that point is because someone's done the hard work of research. We need you included in this data so that we can offer you the best care. So I think that's where we come in.
Dr. Perry?
Sorry, just one more point on that. So, from a practical point of view, one of the things that we have recognised in our recruiting to other studies is that actually often that trust needs to build up gradually. And that actually means it's really difficult to get women into studies at 8 to 12 weeks. Often, actually, you might meet them for the first time at 8 weeks. They might need a further discussion at 8 or 12 weeks. They might actually need a third discussion. And actually, maybe only after having seen you and known you on a couple of visits do they actually feel ready, perhaps, to commit to a study. And so one way that we have dealt with that in planning Domino is actually to keep that recruitment window quite broad, and also to make alliances. For example, if women are migrating into the UK, for example, can they actually join at a later date, to make sure that we're not inadvertently, accidentally excluding women who need a bit more time or for whom that trust needs to develop. There's no clear, and easy solutions to this, and I understand that we are dealing with often a lifetime of bad experiences, and to counteract that, I don't think you're going to do in one appointment, but it has to be part of the journey in pregnancy for us as clinicians, trying to build trust.
Thanks very much. So the really final question, Dr. Perry.
No, just really a comment to say that. Thanks for sharing some amazing things going on. But I guess one comment really was looking at going back to the question around research and development, and also the work that you mentioned around culture. And I guess just emphasizing that one of our biggest problems, and maybe it's something for us to consider, is the system cannot fail those that it was created for. This is what WDP say. And I think where we know that the systems are failing, we can keep on perpetuating that, no matter how much we're trying to do with good intentions, but the system will keep failing. And interestingly, a lot of the issue around men being excluded is, once again, come from a very individualistic culture. So sometimes we focus on the individual, but people live in an ecosystem. To be thinking about our interventions and approaches to be systemic, that way we engage everyone, not only the men, but also some of the women. I guess really some of the key things I think in research is how we package in research. No one can know the chocolate inside unless someone opens it out. And I guess it's thinking, how are we engaging the communities, really from design, but only presenting studies, and whether people don't always want to come to some place. Can we actually work with people in their communities and get some really interesting questions that work?
So,
great idea.
We haven't got one of those prepared earlier. So just thank you all for your participation. I'm sure everybody wants to have, the food was actually rated very, very highly last year. So I hope you all enjoy. Some people are nodding knowingly because people had thirds, would you believe? So I'm going to start the video, but we've got till 1:30 to have your lunch, okay? So enjoy that. Again, lots of networking, lots of questions. The panel, I think, will be at lunch, yeah? So if you didn't get a chance to ask your question now, please ask them. If you want to participate in our draft toolkit for pregnancy, please come and see me and give me your email address, and I'm going to start the video. So if anybody wants to forego 10 minutes of their lunch, please feel free to do that, because it's always good to hear somebody with lived experience, their voice.
Hi, my name's Tilieka, and I was diagnosed with diabetes in 2020, but there is still a bit of uncertainty surrounding what type I am. I'm currently 36 weeks and 4 days pregnant, and I am booked in to be induced at 37 weeks, so that's this weekend. And just wanted to speak about my journey being pregnant and diabetic. Before I actually got pregnant, I felt as though the support was a bit lacking. And I had sort of my reviews, I think 6 months checkups and things like that. I did miss a couple and they weren't like followed up or rescheduled. Well, I think I missed one due to COVID. So that was like a whole year without having a consultation. I did have one at the start of this year. So that was the start of the journey. So January, the job that I was working was very stressful, and where things were in life, I was in a pretty bad place. So my sugars were also in a bad place. And I felt as though the support was not there in terms of my consultant. I do think that was just that consultant. So I don't put it all down to like the medical system or anything, but he was very unsupportive. He told me to just keep taking my medication, which I was doing. So I'm like, I'm taking it, it's not working, so we need to try something else. I told him one of the medications made me feel unwell, so I wasn't taking it as consistently. He told me that was rubbish, like it's in your head, things like that. So my HbA1c wasn't where it needed to be. My sugars were continuously high, and there wasn't much done to bring it down until I kept pressing. He changed the background insulin that I didn't like, and then also tried me on metformin. So because there was uncertainty surrounding my diagnosis, I was treated as type 1 for about 3 years, to which they then looked into it and reviewed it, but was still unsure. So when I had this meeting, he also told me don't try and get pregnant. Like he'd asked in the past, as well as that day, do you want to get pregnant and things like that. Obviously, my husband and I were recently married, were relatively young, but in my eyes, getting on a bit. So we were planning to start a family soon, and he had just completely put me off. He said, don't get on contraception. You'll probably have a stillborn or miscarry, which obviously these are, to most women, nobody wants that. So that really put me off, traumatized me. I was a bit down as well, and I would have just completely stopped trying. So luckily, I was actually already pregnant, or got pregnant in the following weeks, because I know I would have stopped trying after that. It did really get me down, did knock me a lot. And that is a big part of my journey, because if I'd listened to him, or if I wasn't already pregnant, I'm just thinking, where would I be currently? Like, I'm getting ready to meet my baby next week, which is exciting for me and my husband. Since being pregnant, finding out, so they've changed one of my medications, which has made a massive improvement to my control. And then it's been consistently like that throughout. Obviously, I've been told your sugars get higher the further you go along in pregnancy and things like that. I've been told it's harder to manage. You need to keep it this way, or this could happen. Like, there's a lot of things you are told that can be quite scary. So I've been, trying to follow all the guidelines, eating at a certain time, and honestly, considering what I was told in January, I've had the most seamless pregnancy. It's been pretty perfect. I've had hardly no sickness, no symptoms that most people do have, which has been a blessing. I've been able to stay pretty active throughout. So it's been a really nice experience. And because I am pregnant, the support and the care has been a lot more intense. They're on your case, in terms of managing your sugars, but there are a lot more regular reviews, looking at your data, changing your ratios and things like that, which I believe to a certain extent, I feel like that should be a standard for diabetics. And I wasn't given that consideration beforehand. So over the first 3 years since being diagnosed, I feel as though I've deteriorated. So it was only until I got pregnant that things have started to look better. Management's been way better. Figures have been better. HbA1c has been better. And that's because they've actually sat down, looked at my data, looked at my day-to-day living and what can be changed and put in place. And there are still some grey areas surrounding, obviously, things like cultural foods. Like, as a Black woman living with diabetes, every guideline that is given that I can follow, because I come from a cultural background where sometimes we have big family events where there's lots and lots of food, or you have elder relatives where you can't really say no to them giving you food, or it might be frowned upon to just take out your medication and things like that. And then there's a lot of stigma or lack of education surrounding diabetes. So you don't want to let people know, oh, I'm diabetic, or I don't want to eat as much as I would normally eat, of all the foods that I would normally eat because of this diagnosis. Things that I would like to see changed in the future. So, as I mentioned, I am booked for my induction this weekend. I have asked about what would happen if I didn't get induced, because it's not been explained that clearly. So from the start, I was told, oh, your baby will probably be big, you'll probably be induced early, things like that. But I wasn't told why. I have asked a few questions in more recent weeks, but it's still not that clear. So I'm told that my baby's stomach is bigger, which they then say things like, oh, their shoulders could get stuck, which obviously that just scares you into saying, yeah, okay, I'll do whatever you advise. They say that because I am diabetic, the baby could have more fat around the shoulders. So it's like things like that I've never heard of before. So I'm learning a bit. I have been taught a few things, but then I think about things like BMI, which is based off of like Caucasian muscle mass and things like that. Is it accurate? How do we know if it's accurate? So I don't want it to be a thing where I'm induced 3 weeks early unnecessarily. I much prefer a natural method, the same throughout life. Like, I was healthy for 27 years. I don't like taking medication, don't like to go to the doctors, but then I've got this diagnosis where I have to rely on medication. So it's a big transition. With that comes a lot of anxiety. So I feel as though I have a lot of overthinking and anxiety now compared to before I was diagnosed, because of living with such an intense disease. And obviously that doesn't really help when it comes to being a first-time mother, because you've got all these what ifs and unknowns. There needs to be more clarity surrounding the figures, what is deemed as above average weight and size and growth and all of that, because some days I'm like, in the middle I was very big, but then some days I feel very small, but then they're telling me I'm ready to have this baby. So there's a lot of uncertainty surrounding is this an overall thing, or is it just because of my genetic makeup? Is it because of my baby's genetic makeup? Is it because of the foods I'm eating? Things like that. There's no clarity surrounding that. So I would like a lot more information on that. And then also, in terms of preparing for pregnancy, like, I was not prepared at all, especially being told you're not where you should be, figures are not this, nothing. But from that specific consultant, there was no plan put in place or no changes put in place to say, this is what we're going to do to prepare you. It was almost as if, well, we don't want you to have children. And if you're not going to sort out your sugars, then you're not going to be able to have children. So, yeah, it's been an interesting journey, but one thing I regularly say is just trust your own body, because you know when something's not right or when something doesn't feel quite as it should. So sometimes you have to get a second opinion, and I'm just glad that I didn't fully listen to that doctor. Otherwise, I wouldn't be where I am today. My sugars are well controlled. At my last appointment, the diabetic midwife was like, "These are some of the best figures I've seen," which I was really told throughout, but I've really tried hard to keep on top of it, to eat well, to eat at specific times and things like that, which obviously if you live with diabetes, you know it's a never-ending roller coaster. You can do everything the same each day, and it doesn't always work out the same. So yeah, it's been a journey, and I'm glad to be coming to the end of it. I'm glad to get to meet my baby early, but I'm still not even 100% sure why, in a sense.
Thank you for staying, and I do hope you get your lunch. I just want to let you know that Bernadette said she's had her baby.
Healthy baby.
She's had her healthy baby.